If you look on the second page, a lot of what you have to know is written there for you. However, I kind of wanted you to understand some of the more complex things that students have a problem with. So when we're looking at IV fluids, we have to remember how to start an IV. Okay. We have to remember what fluids to choose. We have to remember the blood transfusions, which will not be a big part of what you need to know, but it may play a little bit of a role. So you have the blood administration packet for that purpose. You have to keep in mind that the IV gives us the #1 hospital-acquired infection, which is called bloodstream infection, BSI. So we have a lot of hospital-acquired infections. Bloodstream infection is #1. Ventilator-acquired pneumonia is like #2. C. diff, #3. In other words, we gave them these infections from our lack of hand washing and aseptic technique. So when you go poking holes in people, you already know from fundamentals that you invite infection. So that's a big deal. Now, when we're looking at choosing an IV fluid or why the physician ordered a certain kind of fluid for the patient, and you do have to know, unfortunately, what the physician knows, because as you move into these teaching environments, you're going to be with residents who are wonderful, but they need to be taught. And they're going to literally turn to you, sometimes with fear on their face, because the resident above them is on their shit. And they will look to you and they'll say, "Can you help me? What fluid should I order?" It's okay. It's their first month. They'll get really good, and some are so good that you're going to choose them for your own doctor like I have. You watch them grow, because you're in nursing 20 years. I've had residents, one of my favorites, shout out to Dr. Margaret McKenzie. She was an intern. I watched her. She was the smartest one in the bunch. And now she's my doctor. So, and she said it was the greatest compliment ever for a nurse to come to her. Okay? So you're going to be okay, but you got to know what they know. So when choosing fluids, if I'm getting a patient through the ER who's in DKA, I'm not going to wait until I get an order. I'm going to pull a bag of normal saline, spike the bag, hang the bag. When the patient arrives, I'm ready. You don't wait. You don't want to wait ever. You want to be boom, boom, chop, chop, let's go, boom, okay? So when we look at the hypo-hippo issue, and we're looking at what is it about hypotonic solutions. When we choose to give a hypotonic solution, we got a nice trick for you. We thrive on tricks here. It's just really hard to remember. Look at the double digits, sorta. 2, 2, 3, 3, 4, 4, well, a little bit off. But that's how you're gonna remember it. Your hypotonic solutions, 0.225, 0.33, 0.44, but not really, 0.45. That's how you're going to remember hypotonic solutions. Usually you have double digits that are very close in each other. They're twin numbers, 2, 2, 3, 3, 4, 5, but kind of like 4, 4. But you'll remember because it'll be on the test. It's not like you have to write it in, okay? They all have normal saline. Sodium chloride is the one with the 2, 2. Not that big a deal. I think you'll be fine with just the double number kind of rule, okay? Now, what in God's name does a hypotonic solution do? Well, it causes fluid to move into the cells. So who would we use it for? Someone who's lost water out of the, here you go, intracellular compartment. Loss of water from the intracellular department, which is severe dehydration, right? Loss of fluid from the intracellular department, you're going to choose a hypotonic solution. And it's going to put water into the cells to make them fat like a hippo. Hypo gives you hippo cells. That's cool. You all right with that? Okay. All right. Now let's go to the next one, right? Oh, and if you look, I wrote a little bit of something there. I put for my little write-up on that page where it says Hypotonic, and so it's kind of like you turn the page and you'll find it at the top. Yeah, at the top of the second page. Yeah, there it is. If you go down, at the top it'll say IV bags and tubing. Does everybody see that? Okay. So you got your little IV bags and tubing. And you go down a little bit, you'll see hypotonic. And it's less sodium concentration than blood. If you look at the board, you had to remember that yours and my blood matches normal saline, the sodium content. Well, normal saline was 0.9. Remember, everybody? Okay, but look what we did. We gave you less sodium. We gave you 0.4, 0.3, 0.2 less sodium than our bodily fluids. Okay. Now, so, of course, we would use it for severe dehydration. Not typical dehydration, severe, really outrageous, severe, crazy dehydration. If I'm honest with you, in the real world, we very seldom use this because we very seldom see that severe of a dehydrated patient. So the next two become the more important ones just as you go through your career, which I know you can't imagine, but it's coming. This is the hardest course. Everything else is much easier. So the next fluid is hyper or hyperact. Why did I put that? Hypertonic. Well, no, I did put that right. I did that right. Hyper or hyperactive. What happens if you're hyper? You lose weight. Activity makes you lose weight. Hyper. Really fast motion. You know, hypertonic solutions. Hyperactive people. Same thing. Skinny cells. So who is it for? It's for somebody with too much fluid. And if you use the hypertonic solution, you're going to do what? You're going to cause the fluid to move out. It moved out of the cell, creating a skinny cell. So who do we need that for? Edema, neuro. Why neuro? Because that's called cerebral edema. So if your brain cells in your brain, your head, are filled with water called cerebral edema, causing ICP or increased intracranial pressure, well, you better believe you got hypertonic solutions hanging. What's the best example of this? Please know it. SIADH, which is another name for hyponatremia. And I just got to tell you, it doesn't matter if I'm teaching med students, nurses, or nurse practitioners. That's on every test. What I just said is on every test. The fact that the number one person for a hypertonic solution is SIADH, another name for hyponatremia. natremia on every test. Specifically, the type of IV solution I would use for SIADH or hyponatremia or neuro patients with ICP, traumatic brain injury, ICP, 3% sodium chloride. Put little stars by it. Put some stripper glitter on it. Because it's important as hell. D10W is another one. I do want to give you a little tiny bit of love on that one. If a patient has a TPN, total parenteral nutrition, and it came up from pharmacy kind of contaminated, like tan colored, cloudy, crazy looking, which can happen. Of course, you'd send it down to pharmacy, but you still need to hang something. We can substitute D10W for TPNs because TPNs are hypertonic solutions as well. The one that every neural unit has on it, like every neural unit I've ever been on, has D5.5 normal saline. And yes, I would remember that. Now watch this, I bet you will agree. We said we need hypertonic solutions to pull fluid out of the cell and make it skinny, right guys? Wouldn't you agree that the dialysis patient has a lot of fluid in their cells? Okay, so dialysis solutions that we use to get the fluid off the patient, those dialysis solutions are hypertonic. It pulls the fluid right off the patient. Mannitol, which you may or may not remember or even know about, this is a medication we use for ICP, and you might as well get started now understanding it's hypertonic. So here I wrote, great for neuro patients. If you look at what I wrote here on my procedures packet, it says more sodium in the solution than blood. It's used for fluid volume overload for some of the patients. It's appropriate for that. Edema, neuro. Okay, so you have all those. And then in parentheses, because I told you it was important, you have the 3% sodium chloride for SIADH. Okay. Next, and the most commonly used solution that I use every day of my career, is isotonic solution. And I think it's Mike Lanier. He's got all this stuff on his webpage. I love him. If you don't know him, get to know him. You'll need him for, for 2501. So here's all this stuff on there. And he said, ISO perfect for isotonic solutions. In other words, don't mess with perfection. Just keep the sodium concentration the same. Because this patient does not need, watch this, this patient does not need a change in their osmolarity. They don't need a change in their osmolarity. And these solutions do not change the osmolarity. Osmolarity normal is less than 300. I suggest you write that. Normal osmolarity is less than 300. Sort of probably better know that. Now, so what's going on with these fluids? Well, they're the exact same concentration / osmolarity, because the word concentration and osmolarity mean the same thing. They're the exact same concentration or osmolarity as bodily fluids. So if you have a patient that has lost bodily fluids as in the patient who just had a baby because they lost blood, as in the trauma victim who came through with the motor vehicle accident, as in the patient who just had surgery and their bodily fluids are sitting in a little canister with suction. All of those patients are appropriate for isotonic solutions. Any loss of bodily fluids like that. So every single one of those units has isotonic solutions on it. In maternity, we got lactated ringers. In the OR, we have LR and normal saline, lactated ringers and normal saline. In the ER, we have normal saline. Some people get lactated ringers. These are isotonic solutions. Remember in your notes, you can bolus this. These are the fluids you can bolus. You can never bolus sugar. If it says D5 anything, you cannot bolus sugar. You will get into major trouble with your patient doing that nonsense. And I've seen it, so I want you to not be dingy. You cannot bolus D5 nothing. D5 normal saline, D5 and a half lactated ringers, D5W, D50 this, D this. No, no Ds. No. You're going to get somebody very sick. Don't open the IV wide for those patients. Okay? Now, so here we go. Just a little side note. I wouldn't go crazy with it. Side note. Lactated ringers has, practically speaking, a lot of most of the electrolytes in it. Tiny bits. Not enough to make you go crazy with an EKG. Just little tiny bits. It has sodium chloride, potassium, and calcium. I already wrote it's great for the operating room or the maternity patient. However, if I'm trying to decide between lactated ringers and normal saline, there are some people I prefer normal saline in, and the normal saline patients the patients that I prefer normal saline in, definitely DKA. Because if you think about it, as we said Tuesday, DKA can come in with some funky potassium. So why add to that funkiness with an LR-based solution? Plus, you can get into, here we go, write it down. You can get into lactic acidosis for a patient who's already acidotic. So when we say lactated ringers, you could, if you gave it to the DKA patient, you could lead them down a slippery slope of lactated acidosis. Lactated acidosis. And they're already in acidosis. They're DKA patients. Okay, so we're not trying to, make things worse here. And you don't want to play with the cake too much. We also don't use lactated ringers with liver disease. So normal saline is preferred. Normal saline is preferred for the liver disease patient. And it doesn't matter which fluid you use. Pretty much any of them will do for trauma or ER. So emergency room, trauma. Doesn't matter which one. They both are good. They're both wonderful. Okay. All right, so you got that. Now, just some side notes here on your central lines. We have everything you ever needed written on your procedures packet, except I want you to go with me right underneath the IV tubings. Do you see where it says midlines? Okay, you got to know this. Under midlines, remember how long they are, 3 to 10 inches. I want you to highlight where it says not a central venous catheter, CVC. Does everybody see that? It's not a CVC. CVC is short for central line. It is absolutely not. And look where the tip stops. It stops just below the axillary line or vein. Please highlight that. It's already written. You don't have to write it. You just need to highlight it. Okay? All right. Now, so what did I write on the board? The same exact thing. Wrote the same thing. You're going to be all right. Okay? Now, so what do we do with it? Well, I'll tell you what we do. We have these lines for the elderly because they're so hard to poke. And so we like these for our geriatric clients in long-term care. I'm telling you that now. And we like it, look what I wrote, for patients who need IV therapy longer than 7 days. We can leave it in a month or so. We love it. Now, it does not allow you to give vesicant drugs. So it still tells you no drugs with a pH less than 5 or greater than 9. Those are called vesicant drugs. You still can't give vesicant drugs even if it's a midline. Some people get a little confused about that in the community. It's not like a little mini central line. No, God, no. Okay, so you're not going to do that nonsense. RN or the doctor can do it. Ultrasound guidance is fine. Look what's not needed. What's not needed? X-ray confirmation, not needed. Boy, is that a blessing, because you don't have X-ray machines hanging out at the mall at long-term care facilities or in the house. You can get one of these lines and you'll be fine. So we got that. Now let's talk about these central lines. Obviously, if the tip of the central line, and it doesn't matter which one, whether it's a Broviac Hickman, a PIC, a PAC, a Swan-Ganz, whether you're doing CVP monitoring, it doesn't matter, port-cath, Metaport, triple lumen, doesn't matter. All of the tips sit in the vena cava, the superior vena cava. If you look at what I wrote under central lines, I've already hooked you up. I wrote air embolism. That pneumo is not pneumonia. I want you to be sure you know it's not pneumonia, and you need to write out what it is. It's a pneumothorax. Not pneumonia, it's pneumothorax. Bloodstream infection. DVT/thrombophlebitis. It's not so much a DVT, so that's kind of like a misnomer, but I knew that you would understand that that's a clot. It's not deep, it's actually superficial, but it's called thrombophlebitis. So if a patient, as I had here written on the board, if a patient gets phlebitis, if you're not careful, it can become thrombophlebitis. Okay? All right, so that's what we're saying. Okay, now, just so you know, all TPNs are central lines. That's first on the list. You see chemo, everybody see chemo? You guys see the TPN? And then ABGs, arterial blood gases can be pulled from them. Serial lab work, so you quit poking the patient. Vesicant drugs is one of the #1 reason. Look how I keep saying what the definition of vesicant drugs are. There's a pH less than 5 or a pH greater than 9. Central venous pressure monitoring, that's all the CVP is, okay? You should have chest tubes at the bedside because you could get a pneumothorax, and that'll make a lot of sense in 2501. Let me just say this now. Don't be dingy. Keep every hand out. You're going to be shocked to see all this stuff again. And that's why this is the hardest class, because you're going to see all this crap again. So just keep what I give you, because Monday and Saturday of this week, I am giving all of what you have out again.